Okay, perfect. Like I said earlier, good morning, everyone. My name is John Rickards. I'm a second-year internal medicine resident here at Mercer University, Atrium Health Navicent. Um, interesting and interesting case that we're going to present this morning. It's a unique CRT case involving a reopened persistent left superior vena cava, an anatomical challenge at its face, but it actually became a novel solution for this patient. So I'll jump right into it. I do not have anything to disclose. A bit of background before we get started. CRT in general, at its most basic concept, is a procedure that's done to restore harmony. That's the purpose of CRT when it comes to heart failure patients, especially in patients that have a reduced ejection fraction and also a prolonged QRS, more so a left bundle branch block. They develop what we know as ventricular dyssynchrony and actually desynchronous heart failure. You know, that left ventricle that they have that's already weakened, it's inefficient in its contraction, and that worsens cardiac output and remodeling when those patients go. So several trials have shown that synchronizing that contraction through cardiac resynchronization has actually led to improvements in not only ejection fraction, but hospitalization, quality of life, and more so, more importantly, all-cause mortality. The MADIT trial, the CARE HF trial, and this presentation is actually pretty timely given the fact that in the community there's a lot of discussion around the approach that we take towards cardiac resynchronization. Um, so to move forward into the actual case, what we have is a 71-year-old female who presented to our hospital with worsening heart failure symptoms. At this point, she had already had a CRT um, D device placed. She had an EF that was 30% and did meet that criteria through a left branch and a QRS that was 160. And at that point, she had been maximized on GDMT. However, following investigation on her admission, it was found that her left ventricular lead had actually been dislodged by device interrogation and imaging. So the decision was made by the clinical team and the electrophysiologist to proceed with revision of this LV lead, sorry, this LV lead in an effort to, this LV lead in an effort to hopefully give the patient some benefit and some alleviation from her symptoms at that point, because she came in basically in heart failure exacerbation, and she did before seem to be benefiting from the fact that she had a left ventricular lead. Um, when the procedure was actually initiated, in initial venous entry was complicated by the fact that the guide wire could not be advanced past the actual superior vena cava. At that point, a venography was conducted, and what it actually showed was an occluded right superior vena cava, which I'm using that terminology here, superior su uh, occluded superior vena cava. However, what was apparent by a venography was the fact that now there was an opened left superior vena cava that drained into a dilated coronary sinus. Um, at this point, the decision was made to proceed with implantation of the left ventricular lead through this reopened superior vena cava, which now actually stood as the only access to the coronary sinus in the upper anatomy, venous anatomy of this patient. So first off, a bit of history when it comes to persistent left superior vena cavas. In this context, it's hard to see. However, normally it's associated with congenital heart disease and congenital anomalies. It has about a 0.5% prevalence and 11% when it comes to congenital heart disease. However, in our case, what we opined had occurred was the fact that this patient had a common anomaly associated with transvenous lead placement, which was occlusion of her superior venous occlusion. The back pressure actually led to reopening of that left superior vena cava that likely was not completely obliterated in through embryological progression. So what this does pose, however, is one of the more challenging parts when it comes to left ventricular lead placement became more challenging as the reopening of this left SVC now dilated the coronary sinus further. So to move further, What was concerning during this period was that along with it being dilated, it also increased the worry of dislodgement of the lead. And along with this, the angle of approach also became an issue because in previous literature that speaks towards left SVC, persistent left SVC and the placement of CS leads, the the actual recommended approach is through the right ventricle, which wasn't possible in this patient because that gives a favorable angle of attack when it comes to implanting and cannulating the coronary sinus. However, that wasn't an option here, given the fact that this patient's right SVC was now occluded. So the decision was made to proceed with the use of active fixation leads in an effort to reduce the chance of dislodgement, as well as using steerable sheaths and subselectors. It was discussed during the case that had we not been able to access the coronary sinus using this, that other methods could be implemented, such as epicardial lead placement and also left bundle branch area pacing. Um, and this is just a slide. I know I mentioned earlier that we're looking at coronary cardiac resynchronization therapy, which is the most studied and has the best response rate given the literature that has been published. It has robust RCTs to back it and a class one recommendation. However, the fact that I mentioned left bundle branch area pacing and also when it comes to conduction system pacing, just wanted to show that cardiac resynchronization therapy through a left ventricular lead in the coronary sinus still has the greatest amount of evidence and data to support it. And per the literature also has the best response rates, especially in patients like this who have such a wide left bundle branch block. So to continue with our case, with the use of steerable sheaths and also with a lead that was fixed, we're able to actually access a lateral posterior branch of the coronary sinus through this now reopened left superior vena cava, even though it posed a challenge given the fact that the coronary sinus was now so dilated and traction and the attack angle proved to really be difficult here. But the best part of this is the fact that following this implantation, the patient that previously presented in heart failure exacerbation and actually had an EF of 35%, 35%, now showed that not only did she have improvement in her symptoms and her symptom burden, her quality of life, but she also had objective improvement in her ejection fraction when it was observed at a 6-month follow-up. So the main takeaways here is that a lot of times these procedures, especially when venous occlusion is noted, they're aborted. And we can actually note that venography is critical in these patients to give us an actual insight into what's going on in terms of any sort of venous anomalies and really a clear picture to approach this patient and hopefully give them benefit in the long run. CRT still remains as one of the most studied ways that we do CRT through LV lead placement. It improves mortality and also helps with desynchronous heart failure. And also that just this sort of presentation with a persistent or reopened in this case left SVC, it can complicate lead placement, but it's still possible, especially with awareness and proper preparation. So at this point, I'll go ahead and take any questions in regards to this case. Thank you.
Thanks, John. Thanks for that good, excellent case. I just want to ask you about what was the time frame between the implant to the time the lead had dislodged? What was the time frame there?
So the initial implantation, which was ICD, was done 10 years prior. The left ventricular lead was done 2 years prior to this revision. This revision was 2 years after the left ventricular lead was originally placed.
Okay. Okay. It's quite unusual to get a late dislodgement. You know, I can imagine that you're getting an early dislodgement, but it's quite unusual to get a sort of a late dislodgement at 2 years.
And in thinking about that, I know Dr. Sagari can probably give more insight, but I'm wondering if the actual formation of that venous anomaly after occlusion and, now you have that larger venous pressure might have led to or contributed to the dislodgement. I'm not certain, but.
Yeah, for me, with this persistent left superior vena cava patients, people who have had total occlusion to denominate. And I find it very difficult to place leads in them. Oftentimes, when you do venogram, you won't even see the branch. And so you have to implant them, you have to use an occlusive balloon close to the horse of the vein to get an idea where a branch may be. And I think the beauty now that we have, I haven't done, it's like one of those things you run into very rarely. And for CS lead placement, it's been shown to be very difficult. But now that we have this active fixation lead in the CS epicardial leads, I think it's made maybe a bit more palatable. And this was a case that was done by Dr. Poku. And I think perhaps for me, the dislodgement may be more to do also with the anatomy itself. That this a high flow, but the interesting thing is that when the vestigial innominate occluded, it led to high pressure, which recannulated this thing to a main route of venous return. So that's been my own experience. I don't know if others have tried to put a LV lead through a persistent left superior vena cava. I think Professor Mavat had some comment here.
Yes, very nice case, John and Felix. Yes, we did this with one of our colleagues, Dr. Haytham Badran. He showed us when he had to go to this persistent left superior vena cava in order to implant the CS lead. We had also other cases when a patient needed a dual chamber pacemaker, and there was only the persistent left superior vena cava as the only vein in the patient, and we had to go to both the right atrium, which was easy because the vein opens into the CS into the right atrium, but we have to do some manipulation like S-shape curve of the stylet in order to enter the right ventricle. The problem is of the presence of this CS lead, the quadripolar lead. Of course, fixation is important. Inside this huge venous chamber, which is the presentive superior vena cava, this increases the chances of dislodgement. I have a question to you, Felix. Uh, as you see, he showed us obstruction of the right superior vena cava after many years of implantation. Why do the guidelines not recommend anticoagulation when you place when you implant pacemaker in patients with some risk factors? We haven't heard this. Nobody indicate anticoagulation after implantation of devices, but
Hmm.
we see this a lot when we upgrade or when we extract these leads. This is the first question. I have another question. We answer this and give the second question.
Okay. So I think for the anticoagulation, because I think the rate is still very low, and sometimes I kind of made an observation, maybe something for us to systematically look at. When I did a lot of submuscular implants, I think there was a slightly higher rate of, mostly subclavian vein occlusion and, but SBC occlusion by itself is kind of rarer. But when we're doing extraction, maybe based on tortuous anatomy, some people will just, occlude there, and you notice that that's where they have occlusion, but they form collaterals. So you don't see it as a clinical issue. But when they have subclavian vein thrombosis, you see left upper extremity swelling and things like that. I think definitely it would be nice to maybe look in our own records, maybe collectively, look at those patients that have had thrombosis, in the extremity. Is there a common characteristics we can identify in them? The technique of access, did we have to, stick many times? Did we have to, did they develop post-procedure hematoma? What are the risk factors? I think it would be a nice study for us to do collectively, looking at maybe retrospectively, all of us looking at those patients that have had thrombosis. Is there any common characteristics we can see in them, to maybe now guide us to see whether they should be anticoagulated? But for SVC, it's very rare. But I think unless you have imaging of the vena cava itself, to be able to know this is a tortuous vena cava or not. I think that may influence. At least that's my own thought on it. I don't know if others have any experience with this. Yeah.
The second question from myself and Dr. Muhammad Sami, who wrote it, why didn't you do extraction of the CS lead, the non-functioning one, and use the sheath to introduce a new CS lead through the same route?
Yeah, I think definitely I'm not sure what the consideration will be. In our own institution, we tend to be we do extractions mainly, if the patient wants to, or if there is infection becomes a class 1. We definitely do not want to have multiple abandoned leads because that will preclude this patient now from being an MRI candidate. But at least from our institution, though others have shown that that's not a real factor. But I think it's just probably a clinical decision that trying to extract this, you may damage the other 2 leads that are good, and you have to be prepared to replace everything when you have an occluded vena cava. And if you're trying to extract the CS lead, even though we use laser, but there's still a risk of injury to the good leads. And so you may end up now having to fight for 3 leads, That is a concern, I think, that will probably weigh in this decision making. Yeah.
Yes, yes, I have the same opinion like you. I wouldn't go and extract the lead to place another lead and damage the rest of leads. So, by the judgment of the operator, yes, go to the perfused left superior vena cava and implant a screw-in lead, quadripolar lead, and they
Yeah.
should be available. They are made